I'll be talking about the role of precision oncology in CA prostate and what has happened apart from the paradigms which are already existing, that is chemotherapy and the anti-androgen therapies which are already available in the treatment of metastatic CA prostate as of now. So when I go about discussing the latest happenings, the first thing which would come into mind is, let us start with a clinical case scenario. So this is a 69-year-old man who's a known case of hypertension and has a family history of pancreatic cancer in the elder brother. And he's also been diagnosed as CA prostate in 2014 with a Gleason of 5+4, which was localized and high risk. And this patient has been treated with radical prostatectomy. So now, in this clinical scenario, the things which are to be highlighted are that this patient has a Gleason of 5+4, this patient has a localized high risk, and he has undergone radical prostatectomy. But along with all this, there is a family history of pancreatic cancer in the elder brother. So how and why does this pancreatic cancer in the elder brother come into the whole of the treatment paradigm? I'll be coming to later. Now, let us go along with the clinical scenario. From 2014 to 2018, this patient was absolutely fine when he started developing severe back pain for 2 weeks. And then subsequently, the PSA started rising, and from normal, it went to 26 nanogram per ml. And at that point of time, the bone scan was done and the MRI was done, which showed extensive skeletal mets. This were both in the axial and the appendicular skeleton. And fortunately, in the other scans, there were no visceral metastasis. So after 4 years of being absolutely normal, the patient relapsed and this time became metastatic and has bone mets at this point of time. So had this been 2020, which being 2021 now, the treatment of choice, would it be ADT alone or ADT, that is androgen deprivation therapy, plus something? Because all of us know that CA prostate is a hormone-dependent disease. So the choices which we would think, which would come to our mind would be anti-androgen therapy, that would be abiraterone or enzalutamide, or of course, the standard chemotherapy which was prevailing, that is docetaxel. So the clinical scenario continued. This gentleman was treated with the androgen deprivation therapy plus abiraterone plus prednisolone. And thankfully, the PSA came down to 4 nanograms per ml. Sorry. Patient became asymptomatic. But after a period of 2 years, the patient started developing progressive fatigue and the patient started developing pain abdomen and pain in the sites which were not there earlier, which were in the skeletal sites. The PSA, which had come down to 4, jumped up to 24, and the serum testosterone was again at the castrate level. And this was the PSMA PET, which shows lesions which are there in the bones, lesions which are there in lymph nodes, which have come new, and of course, lesions which are there in the liver, which also have come new. So you have a patient who started from 2014 and his journey encompassed relapse after 4 years, which was 2018. And at that point of time, the patient had a high PSA. He was treated with the androgen deprivation therapy with the GnRH analogs. And along with that, the patient was given abiraterone. And along with that, the patient was given prednisolone. And now, after a period of 2 years, that is 2018 to 2020, the patient started developing constitutional symptoms and has this picture on PSMA PET, which shows the patient has skeletal, that is osseous mets versus hepatic mets. So the patient has developed now visceral mets along with. So now here in 2021, what would be the further line of therapy? Apart from the standard anti-androgen therapy of endosomal and abiraterone and chemotherapy like docetaxel, the newer changes which have come are the role of the PARP, that is PARP inhibitors. There is an advent of immunotherapy now. There is a role of theranostics in patients who have been heavily pretreated earlier. And I would be discussing something which is the very latest, that is the PI3K and the AKT pathways. Coming to the PARP inhibitors, when we see metastatic prostate cancer, it has germline DNA repair mutations. And based on this study by Pritchard in NEJM, which was published in 2016, they found that out of 692 men, about 12% men with the metastatic prostate cancer had germline DNA repair defects. So these are all the germline DNA repair defects which are there. And 76% of the 12% which are found to be positive, the commonest were the BRCA1, BRCA2, ATM, and CHEK2 mutations. And amongst all these, BRCA2 was the commonest. But a thing which was there, which is important to note, that all men with germline mutations had a family history. Not all men with germline mutations had a family history of cancer. So we find that 12% of men with metastatic prostate cancer have germline DNA repair defects. And if they have these repair defects, the commonest are the BRCA2, then comes the ATM, CHEK2, and BRCA1 mutations. Now, the obvious question comes, which patients should be tested for germline mutations? Because if we find that 12% of metastatic prostate cancer patients have these mutations, then the patients who have metastatic prostate cancer, they are the ones which should obviously be treated, checked for the germline mutations. Those which have a known DDR mutation, that is BRCA2 or BRCA1 in the family, they also are the ones who should be treated. And those with a positive family history for cancer, regardless of the stage of disease, they also should be treated. So to make it simpler, patients who have metastatic CA prostate, patients who have a known family history of BRCA1 and 2, and patients who have a positive family history of cancer, they are the ones should be tested for the germline mutations. And against these mutations, these are the drugs in which the trials are going on. That is veliparib, olaparib, rucaparib, niraparib, pamiparib, and there are another host of drugs which are there, amongst which I would be focusing on olaparib and rucaparib, in which the trials have been robust, and based on that, they have got approval from the FDA. So coming first to olaparib, this was the registration trial, that is the PROfound trial, which was a phase 3 trial. And this was pitted, that is olaparib was pitted against the physician's choice in progressing metastatic CRPC. So these were the patients who were harboring the genetic alterations, that is BRCA2, BRCA1, ATM, or any other alterations which were found in CA prostate. So the commonest, which I have told you, that is BRCA1 and BRCA2 alterations, or the ATM alterations, were taken into one cohort. And the other alterations which are seen in CA prostate, the germline mutation, they were taken into the other cohort, that is cohort A and cohort B. Each of these cohorts were randomized in a 2:1 fashion, in which olaparib was given against the physician's choice of treatment. And both of these cohorts were followed up till progressive disease or till intolerance with the drugs. The primary endpoint in this study was radiographic progression-free survival in cohort A, and secondary endpoints were the radiographic progression-free survivals in both cohorts, and of course the overall survival and the tolerance profile in these patients. In the PROfound trial, it was found in the final survival, the patients who were in the first cohort, which had the BRCA1, BRCA2 or ATM mutations, they had a significant median overall survival benefit, that is about 5 months, 19.1 months against 14.7 months in the AR therapy, that is the androgen receptor therapy. And against, when you see the overall population, there also there was a median overall survival of 17.3 with a very good hazard ratio of 0.79. So based on this, the FDA approved in May 2020 olaparib for metastatic CRPC with deleterious or suspected deleterious germline or somatic mutations, this drug. But this drug is also having its own side effects. And the commonest side effects were fatigue, anemia, and nausea. These were seen in majority of these patients. And these were generally of lesser grade, barring some cases in which the anemia was found in about 21% of patients who had grade 3 or more. Rest all were very, very manageable, and they could be overcome with the dose reductions wherever the case was required. A word of caution was there that in a small percentage of patients, that is about 1 to 2% of patients, they had myelodysplastic syndrome, but that has not been seen in other trials which have been done in the PARP inhibitors with other drugs also. So FDA approved in 2020 olaparib for metastatic castrate-resistant prostate cancer with these HRR gene mutations, that is germline or somatic BRCA1, BRCA2, which are the commonest. And the patients which were included were, they were the ones who had taken previous treatment with enzalutamide or abiraterone. And, this was supported by the radiological progression-free survival as it was in the PROfound data, and also was supported by the confirmed ORR or OS outcomes. So you have one drug, olaparib, which can be given in metastatic CA prostate in patients who have progressed on one line, that is treatment with enzalutamide or abiraterone in castrate-resistant prostate cancer. The other drug which is there, it is rucaparib. This is again another PARP inhibitor. And the effect of this was seen in the Triton-2 study. This Triton-2 study was a phase 3 single-arm open-label study of patients with deleterious somatic or germline alterations in castrate-resistant prostate cancer population. And as you can see in this waterfall plot, there is confirmed approval, confirmed benefit in these patients, almost 90% of patients who had a change of PSA from the baseline as compared to patients who didn't have. So this had again a confirmed radiological response, which is ongoing, and also was efficacious in patients of CRPC who had undertaken one line. So based on this trial, that is the Triton-2 trial, the FDA approved in May 2020 rucaparib for metastatic castrate-resistant prostate cancer patients who were previously treated with AR-directed therapy and taxane chemotherapy. So if you have given a patient one cycle or one set of AR-directed therapy, that is abiraterone or enzalutamide, or you have given these patients taxane, that is docetaxel, and they have progressed, and then we find that these patients have a BRCA1 or a BRCA2 mutation, then these are the patients who have got a survival benefit of more than about 5 months as compared to the control. That is, as compared to any other taxane or as compared to any other anti-androgen therapy. So finally, to summarize, how are PARP inhibitors used in prostate cancer? PARP inhibitors are currently used for the treatments of adult with metastatic castrate-resistant prostate cancer only. This is not castrate-sensitive prostate cancer. This is castrate-resistant prostate cancers. And which mutations in the DNA repair genes benefit from PARP inhibition? So the most sensitive and the most common, which I told you that accounts for about 70% of all the DNA mutations which are there, BRCA2 and BRCA1 are the most commonest, and the rest are the PAL-B2 and the ATM mutations and the CHEK mutations. So you can use olaparib or rucaparib in these situations. And olaparib has been approved by the FDA by the Profound trial, which is a phase 3 trial. Rucaparib has been approved by Triton 2 trial, which is a phase 2 trial, again approved by FDA. And how do you sequence these drugs? These are generally given after the AR targeted therapy, that is abiraterone or enzalutamide. And in these patients, if it is there, you can give olaparib. In case of rucaparib, if they have progressed after abiraterone or enzalutamide or taxanes, then you can give this drug for now. Any combinations which are there with the PARP inhibitors, as of now, it is given as monotherapy, but still up to date, there are phase 2 trials which are comparing combination of olaparib with abiraterone or olaparib alone, and they are also being tried in certain situations in combination with the immuno-oncology drugs. So now switching gears, coming to theranostics, where you do PSMA targeting. What are the new dimensions in that? So before that, we have to see the basics, that is the physics behind that. If you do a PSMA PET scan, which is different from a conventional FDG PET scan. Now, if you do a FDG PET scan, in that the radiopharmaceutical you're using, that is 18-FDG, that is fluorine. But in a PSMA PET scan, we are using radiopharmaceutical, which is gallium-68, which is tagged to the prostate-sensitive membrane antigen. And this goes and hones into the areas wherever there is the prostate cancer, whether it is in the primary site or whether it is in the secondary site. So taking a corollary from the investigation point of view, where you do the PSMA PET imaging with gallium-68, the furthering of this was, instead of using it as investigation, why not use it as treatment? So you label this radiopharmaceutical agent with lutetium-177 or yttrium-90. And that helps in the fact that wherever you have these prostate cancer cells, this lutetium or yttrium goes there and binds with them and leads to cell kill. This was aptly seen in a trial which was published in ASCO GU 2020, in which the eligibility criteria was progressive PSMA positive metastatic castrate-resistant prostate cancer patients. So again, here you have metastatic CRPC patients who are castrate-resistant prostate cancer, which is metastatic. And these patients were the one who had prior taxane therapy with docetaxel and no prior second generation anti-hormonal agents were given. So you have a patient who was initially castrate sensitive prostate cancer. That patient was given docetaxel. And when the patient relapsed and became CRPC, that is castrate resistant, in this 200 patients were taken and they were randomized to give lutetium PSMA 617 for a maximum of 6 cycles versus cabazitaxel, which is the standard again, the present standard, for a minimum of 10 cycles. The primary endpoint in these patients was to see for the PSA response rate, that is, which patients were the ones who had more than 50% response rate. And in this, it was found out that the response rates in cabazitaxel were inferior. That is, this was about 37% as compared to the lutetium, which was about 66%. So this was about 29% greater, that is, lutetium was 29% greater fall in the PSA values vis-a-vis the patients who had taken cabazitaxel. So this study is being further checked because this is a phase 2 study. There are phase 3 studies which are going on now. And this is the phase 3 study, which is the VISION study, in which directly now patients are being pitted who have been treated earlier with the taxanes or anti-androgen therapy. They are being randomized in 2:1 fashion with lutetium versus best supportive care. The primary endpoints at this point of time were overall survival, and the secondary endpoints were the radiological progression-free survival. So these are the patients who are being looked into, and the results, will be showed up later on after the accrual. We also had done a study at Rajiv Gandhi to evaluate the response in patients with metastatic CRPC undergoing systemic radiotherapy or nuclear medicine lutetium 177 PSMA antigen. So this was a comparison between response evaluation criteria in solid tumors, PET response criteria in solid tumors. And this showed that the molecular criteria performed, that is the molecular criteria of the radiological response with PET, can perform better in response assessment by gallium, that is the PSMA PET-CT, in metastatic castration-resistant patients undergoing PARP. And this was the protocol in which 200 millicuries of dose were administered. 4 doses at 8 weeks interval were given, and patients were followed up with gallium scans at 6 to 7 weeks prior to the next dose. And the outcomes, which were the PSMA, PSA scan, symptomatic relief, and performance status, all were better in those patients who were subjected to this dose of 200 millicuries of lutetium. Now, again, coming to a next topic, that is the immuno-oncology drugs in prostate cancer. How can you harness the immune system in prostate cancer? We have seen that, like other cancers of the lung, the RCC, the urinary bladder, the breast cancers, there is a PD-L1 expression in prostate cancer. And if you see the hormone-sensitive radical prostatectomy specimens, they express a moderate to high level of PD-L1, that is more than about 50% in these cases. And patients which have been progressing on enzalutamide have significantly increased PD-L1 or dendritic cells in the blood compared with those not progressing on treatment. So taking a cue from this, we thought that let us see if there is any microsatellite instability in prostate cancer. Then again, the microsatellite instability was found in about 3.1% of patients of prostate cancer. And it was seen again in 2.2% of patients who had high MSI sensor scores. And out of these, you have 4% who have the MSI sensor analysis. And it was seen that amongst these 4%, 21.9% had pathogenic germline mutation in a Lynch syndrome associated gene. So how do we interpret this data? How do we interpret that patients who have a microsatellite instability in prostate cancer, can they be subjected to any kind of immunotherapy drugs? So this was again a trial, a very path-breaking trial in which 86 patients were enrolled to treat with pembrolizumab. Now this was against a diverse group of cancer patients who had colorectal, endometrial, pancreatic, ampullary, cholangio, small intestine, gastroesophageal cancers, and one case of prostate cancer was there. All these patients had MSI high or they had MMR deficiency. So it was found that patients of metastatic castrate-resistant prostate cancer who had MMR deficiency, these patients, when they were given pembrolizumab, this one patient who was given in this study, he had an objective complete response. So this was study which was agnostic of the cancer site, and only factor which was seen was the MMR deficiency. And they found that those patients across all the cancer types who had MMR deficiency, irrespective of the site of the cancer, they were benefited with pembrolizumab. And you had one case of prostate cancer, and this patient, when given pembrolizumab and had MMR deficiency, this patient went into complete response. So after this was tried in a bigger trial. This was the Keynote 199 trial, in which pembrolizumab was given for docetaxel refractory metastatic castrate-resistant prostate cancer patients. So this was planned in 5 cohorts, And the cohort 1 was those patients who were PD-L1 positive. Cohort 2 was those patients who were PD-L1 negative. Cohort 3 was bone metastasis, any PD-L1. Cohort 4 had measurable disease. Cohort 5 was bone mets with no measurable disease. So we'll focus only on cohort 1, 2, and probably cohort 3, who had PD-L1 positive, PD-L1 negative, and probably those who had bone metastasis without, irrespective of PD-L1 or PD-L1 positive or negative status. So the primary endpoint was the overall response rates. And they found that most of these patients had a baseline shift of improvement that is about more than equal to 50% reduction in the PSA values from the baseline. But this was a heterogeneous population, as you can see. The blue ones are the ones with the PD-L1 positive, and the red ones were the ones with PD-L negative. And the change you can see as compared to the population which did not have. So when you see the key response outcomes in cohort 1 and cohort 2, I think we'll focus on these two only, which are PD-L1 positive and PD-L1 negative. The disease control rate at 6 months was seen in about 9% of patients versus 6% of patients. And the ongoing responses were seen in 11% of patients with PD-L1 positive and 9% of patients with PD-L1 negative. So this is again a food for thought for subsequent trials. This was the abstract which was published in the ESCO in 2018. And now finally, I would go back to the basics. That is how you can use the PI3K or the AKT pathway in improvement in the response rates of patients who are taking conventional anti-androgen therapy. So this was the new drug. This is ipatasertib. Ipatasertib has been combined with abiraterone versus abiraterone and placebo alone. And these patients were the ones who were treatment naive, metastatic, castrate-resistant prostate cancer patients. These patients were stratified by the tumor P10 loss by immunohistochemistry and PSA only progression. And these patients had metastatic disease, that is visceral disease, and some of them had been subjected to docetaxel prior, that is when they were hormone sensitive. So you had a group of patients who were initially hormone sensitive, progressed on docetaxel, they were taken into the cohort, or those patients who were CRPC patients, that is castrate-resistant metastatic prostate cancer patients, and they were pitted abiraterone plus placebo versus ipatasertib and abiraterone, and they were continued until radiographic progression or intolerance in terms of the unacceptable toxicities. The primary endpoint in this was to see for the response, and the co-primary endpoints were, of course, the radiological progression-free survival and the survival which was seen in the P10 loss patients, which were checked by the immunohistochemistry. And here you can see that there is a difference in the median radiological progression-free survival, that is about 2 months in those patients who were given ipatasertib along with abiraterone versus those patients who were given abiraterone alone. So this has been stratified by prior taxane therapy and those patients who had PSA progression alone or otherwise. So this is a food for thought, but then it is too premature at this point of time. We have to have a longer duration to see whether these curves, they plateau on or, they tend to merge at a longer period of time. So I think OS would be a more robust marker than the radiological progression-free survival. But at this point of time, you have an option of this drug which can be used as compared to the other drugs. So I think with these new 4 dogmas, I'll stop short here and I'll summarize that PARP, that is PARP inhibitors, have significant clinical activity, and the recent FDA approvals are expected to benefit patients with DNA repair and DNA deficient mutations in prostate cancer. The drugs which have been approved by FDA, they are the olaparib and rucaparib, and these are the drugs which can be used in patients who have progressed in 1-line hormonal therapy, that is enzalutamide or abiraterone, or in case of rucaparib, it can be enzalutamide, abiraterone, and docetaxel. These have to be given in patients who are metastatic, castrate, resistant prostate cancer patients. And PARP inhibitors have to be given as a monotherapy as of now, although there are trials in which they are being seen to be used in combination with abiraterone and other immuno-oncology drugs like pembrolizumab. But for them to come into practice, they have to have mature trials in phase 3 also. The novel immunotherapeutic combinations, as I have shown you, is pembrolizumab. This is being seen, and the biomarker, that is PDL1, that is being utilized. Pembrolizumab are also being tried in combination with abiraterone. It is also being used in combination with olaparib. The final word has yet to be seen, but again, if you have the agnostic marker, that is mismatch repair gene, which is deficient, that is MMR deficient, or you have a patient who has MSI high, that is microsatellite instability is high, these patients, irrespective of the PDL1 status, irrespective of any other status, if that is found in prostate cancer patients, which is found in about less than 4% of patients, these patients can be given pembrolizumab. And I had shown you in that study, in the registration study, that patient who was included with a mismatch repair gene deficiency had a complete response, despite the fact that that patient had progressed on anti-androgen therapy prior. And finally, theranostics, which are targeted towards the PSMA, that is lutetium and yttrium, they are coming in a big way. We are treating these patients at our institute, that is Rajiv Gandhi Cancer Institute, and have had success and a meaningful quality benefit in those patients who were heavily treated earlier, either with chemotherapy, that is docetaxel, or anti-androgen therapy, or steroid therapy, or hormonal therapy like bicalutamide. And these patients, they had a meaningful survival benefit, as you could see in the trial which I had shared with you. That was a phase 2 trial in which the lutetium was pitted against cabazitaxel in the second line. So a lot more has to be seen in precision medicine in prostate, apart from the usual chemotherapy and the anti-androgen therapy which is there. There are so many vistas which are opening, which are very, very promising, and which are very, very encouraging to see. And the last word has not been said till now. So I think I'll stop here. And I thank you for your patient hearing. And I would encourage questions from your side. Thank you.